Hello, my name is Michelle Hampson, and I'm going to be talking about the time course of clinical change we found in our neurofeedback clinical trials. So when I say neurofeedback clinical trials, I'm referring specifically to fMRI neurofeedback. As you've heard from Michelle, this is a technique that has a lot of potential from a basic science perspective because it allows us to change very targeted aspects of brain function and see how that translates into changes in mental function. But it's also a technique that has a lot of clinical potential, and that's what our group is particularly interested in. So if you can train people to control symptom relevant brain function, and that training, that the effects of that training actually persist, then this could be potentially a form of treatment. But a key issue there is whether those effects persist, because you can't really bring people in every day or two to train them, to keep refreshing the training their whole life. So we need there to be some persistence in the effects induced. And there is some evidence from the existing literature that this is feasible for many applications. Some of the earliest fMRI neurofeedback studies followed subjects up for a couple weeks and reported that the effects were still there a couple weeks later. More recently, studies have followed subjects for longer, months to even years, and reported that effects were still persisting. And this is consistent with the EEG neurofeedback literature, which has also reported that some of the effects can persist for months to years. So at least for some applications, in some instances, it seems like you can induce very persistent effects. But for any application, it's actually useful clinically to understand how the effects unfold over time, so that you can see when they wax or wane and when it might be a good time to give a booster, for example. So we're very interested in just mapping out the pattern of clinical change associated with our intervention. Now I'm showing here schematic diagrams. These are not real data, but they're showing on the x-axis time, the neurofeedback intervention occurs during this blue period, and then we're following subjects up over the weeks following. And on the y-axis, we're showing the symptoms in the real and the sham groups. A decrease in symptoms is, of course, an improvement. So if your intervention decreases symptoms in the real neurofeedback group during training, that's good. But if it regresses back to baseline pretty quickly, that's a transient effect, which is not going to be super clinically useful. So what we're actually hoping to see in our subjects is that the neurofeedback will improve their symptoms and that they'll stay in that improved state in a persistent way for a while afterwards. But of course, the reality is we could see any kind of complicated pattern of change. And we don't know what that's going to be, but we want to look at that and map it out. So I'm going to describe to you what we found on this front in two different clinical trials we ran. The first of these was a study of obsessive compulsive disorder run by Mariella Rance, where we were targeting a ventral frontal region and trying to improve their OCD symptoms as measured with the Y-box, which stands for Yale-Brown Obsessive Compulsive Symptom Scale. The other study is a completely different neurofeedback clinical trial. We were recruiting adolescents with Tourette syndrome. The study was run by Chris Walsh. The kids were being trained to control activity in their supplementary motor area with the aim of reducing their tic symptoms as measured by the YGTSS, or Yale Global Tic Symptom Severity Scale. So we're talking here about two completely different neurofeedback clinical trials, recruiting different patient populations, targeting different aspects of brain function, trying to change different aspects of different clinical symptoms and using different clinical scales to assess the effects. But both of these studies showed a kind of interesting pattern that seemed to be common across them. So that's what we're going to be talking about today. I'm going to start by describing the OCD study where we first noticed this pattern. This is a randomized double-blind clinical trial. So subjects were recruited and they're assigned to either receive real neurofeedback or a sham form of neurofeedback. And we assessed their symptoms at 4 points in time before the training. What we call post neurofeedback, which is typically about 3 days after the training, 2 weeks after, and 1 month after. And to give you a sense of what the training was like in this study, I've got a little video that shows you what one of our subjects actually saw during the training. The white arrow pointing forward is cueing them to rest and relax and look at the neutral image. But at other periods of time, there will be a red arrow pointing up, cueing them to increase activity in their target brain area, or a blue arrow pointing down, cueing them to decrease activity in the target area. And during those periods, a contamination-related image will be shown. So this subject is just resting and looking at the activity in their target region, as it's shown in this line graph at the bottom of the screen. now it's going to turn into an increased block. So their goal now is to get the line to go up, and they can look at this contamination image of a dirty stove and think, oh, that's a food surface, it really should be clean. Whatever's going to be helpful for activating this anxiety related brain area. And now it's a decreased block, so their goal is to get the line to go down. They're expected to look at the provocative image, but they can reappraise it, whatever's helpful. So they basically get lots and lots of practice trying to get the line to go up in the red blocks and come down in the blue blocks. And they can see how successful they are. This subject was quite successful, and we felt that perception of success would impact motivation because it's easier to stay engaged if you feel like you can do this somewhat. We also felt that perception of success would impact placebo effects because they know they're trying to control the symptom relevant brain area. If they can see they're good at it, they're more likely to have a large placebo effect. So because we felt that controlling for perception of success was very important, we used what's called a yoked sham control. Yoked sham subjects are matched one-on-one to real subjects, and they see exactly the same time courses as the real subjects and are misled to believe they're getting information from their own brain. But they're not. They're seeing exactly what their matched neurofeedback subjects saw. To the extent that that person managed to get the line higher in the red than the blue blocks, they will be misled to believe they're having the same level of success. So that's all I'm going to say about the methods of this study. If you want to know any more, we have a methods paper with a cheesy video you can watch. In terms of the pattern of clinical change we found in this data, we did see that the real neurofeedback subjects showed symptom improvement that exceeded what we had in the sham group during training, which was encouraging. Then in the 2 weeks following training, both groups showed some symptom improvement. We expected at the month follow-up that they would both start regressing back to baseline as placebo effects wore off, but and the sham group did, but the real neurofeedback group continued to show symptom improvements. So this was actually quite surprising to us. Just to reiterate what we've been thinking, we were hoping to rule out a transient effect where they had symptom improvements and then regress back to baseline. We were hoping to see a stable effect, but what we actually saw was even better than that. We saw that symptoms continued to get better for the weeks that we followed them up. And in fact, the biggest difference between the two groups was at the month follow-up, not immediately post-training. So this might be something idiosyncratic to OCD, but we happened also to have this other data set of Tourette syndrome data, and we thought, well, let's just look at this data and see if we see a similar pattern. So this study, unfortunately, was not a randomized design because for power reasons, we decided to use a crossover design where subjects are recruited and randomized to either receive real and then sham or sham and then real. So every subject who came in for this study had to have 7 consecutive scans, an initial assessment scan, then the 2 scans associated with the training of the first leg of the intervention, then a midpoint assessment scan, 2 more training scans, and then a final assessment scan. So as you can imagine, this is a very logistically challenging study to run. This was run by Chris Walsh, who did a great job collecting the data, but about I think the second subject into this study, he had just finished running the first leg of the intervention and the snowstorm Nemo hit the Northeast and the entire MR center closed down. And I get this panicked email from Chris that he can't do the second leg of the intervention in a timely way because the MR center is not open. And I said, don't worry, that's not a big deal. You can just pause the study for a while, and then before you resume with the second leg, tack on an initial assessment scan for that second leg so that we have a pre-assessment. So once he realized that this was an acceptable design to use for subjects, he ended up using it to get around a lot of other scheduling difficulties. So in the end, about half of our subjects had this design, and about half of them had this broken apart design where we had 2 separate legs of the intervention. So this, differences across subjects is not typically ideal in a clinical trial, but this actually turned out to be a feature for us because these subjects where the intervention was broken apart, that allowed us better map out how symptoms were changing over time in these subjects after the first leg of the intervention. And I'll come back to that in a second. So when we got the finding we had in the OCD study, where symptoms continued to improve over weeks after the training, I thought, well, what would this mean for the Tourette syndrome study? So if we had a subject come in and get real neurofeedback, and then their symptoms were continuing to improve not only during the neurofeedback, but during the weeks afterwards, well, that improvement that occurred during the weeks afterwards would be occurring during the sham sessions. And so it would be attributed to sham. So this is terrible for our power. The second leg of our intervention is going to be, terrible data because our control intervention is going to look much, much more effective than it actually is. And what's actually caused by the real intervention is going to be attributed to the control intervention. So how would that look in terms of the two different legs of the intervention. Well, what we would expect to see is nice clean data from the first leg because there's nothing contaminating it. And then a second leg where the data are much less nice, and the sham subjects in the sham intervention in particular showing much greater symptom improvement because it was actually having symptom improvement driven by the preceding real. So we decided to break the data apart and look at it in that way. When we looked at the symptom changes in the real and sham in the first leg, as expected, they looked beautiful with much better symptom improvement in the real than the sham. But when we looked at the second leg, indeed, it looked nowhere near as good. And the changes in symptoms in the second leg of sham were more than twice the improvements seen in the first leg of sham. So it really did seem like there was possibly a similar effect to what we'd seen in the OCD study, where the prior leg of real was bleeding into the second leg of sham and causing symptom improvements during sham that were actually driven by the preceding real. So we decided to look at this a little more closely. We could look at the precise timing of this post-intervention assessment. So to get information about how the sham intervention affected symptoms over time. We could take advantage of the fact that scheduling was variable at the MR Center, and this assessment sometimes was very close after the sham intervention started in some subjects and quite a while after in others, to map out the temporal changes a little bit. And furthermore, for the subjects who had the broken apart intervention, we can use the pre-assessment scan of the second leg of the intervention to give us even further out information about how their symptoms were changing over time after the intervention. So we do have some information that allows us to map out how symptoms are changing over time after the sham training. And similarly, we have the same kind of information for the real training, but we have even more information for the real training. If we assume that the sham doesn't really do anything, then we can actually take these post-sham assessments as very far out in time assessments of the original real intervention. So that gives us a lot of power for looking very far out in time. And then we can use the second leg of real as well, because we don't expect it to be contaminated by the prior sham. So we actually have quite a lot of data allowing us to map out how symptoms are changing over time after the intervention for the real intervention. So when we throw all these data into a scatter plot, here red is the real intervention, blue data points are from the sham intervention. On the x-axis, I'm coding the number of days after the start of the intervention that assessment was collected, and the y-axis is coding change in symptoms from baseline at that assessment. And you can see that symptoms seem to be improving over time for literally weeks after training in following the neurofeedback intervention. In contrast, symptoms don't seem to be changing much over time in the sham. So this is very consistent with what we saw in the OCD study. And we decided that after doing these qualitative analyses that we should really do a statistical quantitative analysis to see if this effect is a significant effect that's shared by these two studies. So we recruited a statistician, Brian Pittman, to help us with this. And we wanted to roll together the data from the OCD study and the data from the Tourette syndrome study. These are, of course, two totally different data sets. You know, the measures are Y-BOX and YGTSS. These are different clinical scales that have different means and ranges, et cetera. So we really needed to normalize these data in order to combine them. And we did this in a couple of different ways. I'm going to describe just one of these, which we call our Z-score analysis here. So the way this worked is that in the OCD study, we had all these Y-BOX measures, some at baseline and some collected post-intervention. We took just the baseline measures from both groups, including both real and sham subjects, but only looking at baseline. We computed the mean Y-BOX score and the standard deviation of the Y-BOX scores at baseline. Then we normalized every single Y-BOX data point in the data set, subtracting the mean and dividing by the standard deviation. So we put them all into a Z-score space based on the baseline ranges that we saw. We did a similar kind of normalization of the Tourette syndrome data using the YGTSS scores. And then we had both of these data sets in a Z-score space so we could roll them together. And we did a mixed model analysis using fixed effects for our group. Latency was our time variable. This is the number of days from the start of the intervention that assessment was collected. For baseline assessments, it's coded as 0. And for all the others, it's number of days since the start of the intervention. What we're really interested in is a group by latency interaction, because this is what's going to tell us if the neurofeedback subjects were improving more over time than the sham subjects. So when we did this mixed model analysis, sure enough, we found a significant group by latency interaction. And when we explored the nature of that interaction with post hoc analyses, we found it was driven by a significant symptom improvement in the real group and no significant change in the sham group. So that was really encouraging, that real neurofeedback in this pooled data seems to be doing more than the sham in terms of helping symptoms. But it doesn't per se indicate that symptoms were improving, strictly speaking, after the intervention had ended, because it's including the changes that occur during the training. So we wanted to really ask the question, are symptoms continuing to improve after training is over? So to get more specifically at that, we decided to throw out all the baseline data and rerun the analysis using only measures that were collected post-intervention. So now all of the data going into our analysis are collected post-intervention. If we get an improvement in symptoms over time in the real group, this is an improvement that occurred after training. So we ran that analysis, and once again, we got a significant group by latency interaction. And when we explored the nature of the group by latency interaction, it was again driven by significant symptom improvement in the real group, this time, strictly speaking, after the training was over, and no significant slope in the sham group. So this is evidence that the effects of neurofeedback were growing over time after the intervention had ended in this combined data set of OCD and TS data. So you might say, well, maybe this is something weird about one of those studies, and it's kind of driving things and just carrying the result. So we decided to also explore whether the study, TS or OCD, was driving this result. So we included a binary variable coding whether each data point came from the OCD study or the Tourette syndrome study in the model. We also included all the interaction terms of this variable, and none of them were significant, and it did not change the results. In particular, we still got a group by latency interaction in the combined data set. So this indicates that across these two clinical trials, neurofeedback was yielding symptom improvements that grew after the intervention, specifically the real intervention, more so than the sham. So this was quite surprising when we first found this result, and we analyzed the data in multiple different ways to make sure that this was not like some sort of artifact of the way that we normalized across these studies or anything. And I refer you to our paper if you want the details of that, but really we found this finding was very robust to a number of different analyses. And so after we found this, I happened to go to lunch with Nick Turk-Brown, who's another neurofeedback researcher at Yale. And I was telling him about this, and his first reaction was, my goodness, we had the same effect in an open label study of depression that we ran. We didn't really say much about it, but if you go and look at the paper, you can see the effect in the figure. Sure enough, I went and fished out that figure, and this is it from the paper. The follow-ups were collected at week intervals after the training, and here the subjects were improving in their depression symptoms for literally weeks following the neurofeedback training, exactly the same pattern that we were seeing in our studies. And then I started searching the literature to see, what other published studies had data that could be relevant to whether they were expressing this effect or not. And I found quite a number that seemed to suggest the same pattern. I'm not going to go into details about these, but a basic science study that showed just a huge increase in effect 3 to 5 months later. We have also resting state connectivity studies that seem to show similar patterns. I'm not saying that these continuing changes in brain and behavior after training are going to be there in every single fMRI neurofeedback study, but it is a pattern that seems to be present in a lot of different applications. And papers have come out since we published our paper, also reporting that they're getting this effect. So it's been replicated in other studies. So in short, this is a pattern you might see if you're going to run an fMRI neurofeedback study yourself, and you should design your paradigm accordingly. So what I most want to emphasize on that front is that you should follow up your studies, right? If you don't follow up your studies for weeks to months, you could be missing the time point of greatest effect and underpowering yourself. So for example, if you have a pattern like ours where the neurofeedback improves symptoms somewhat more in the real than the sham group, but it's not really clinically meaningful. You might say, well, this is too small, it's not going to be clinically useful, the effects of this intervention. But actually, if you followed these subjects for weeks, you might find a whopper of effect if your pattern looks like ours at the month time point, for example. And when you consider how much time and money and effort it takes to run a neurofeedback intervention, bring people in for multiple sessions of real-time fMRI neurofeedback, compared to how easy it is to phone them up and do a clinical assessment, a 20-minute assessment to gauge where their symptoms are at that time point. It's really well worthwhile to tack on a few clinical assessments later on in order to make sure that you're measuring the time point of greatest effect for your intervention. Also, I would advise against using crossover designs, live and learn. Third, I want to highlight that one of the challenges for people doing fMRI neurofeedback research is figuring out how many sessions of training to use. And a popular approach people often adopt is that they'll interleave assessment scans and feedback scans, and then they'll just see, when do symptoms stabilize, and they'll assume that all the feedback scans up to that point were helpful and were contributing. And then the subsequent ones where symptoms aren't continuing to improve aren't doing anything. But that reasoning is flawed. That reasoning is based on an assumption that the symptom improvements caused by a given feedback scan occurred during the feedback scan, when really our data have shown pretty clearly that in many instances they occur those changes can occur after. So you could have a single feedback scan that causes symptoms to improve for a month. And if you use this approach to try to figure out how many feedback scans you need, you might conclude you need like 12 of them, right? When really only the first one was effective and was doing anything. It's just that its effects took a long time to unfold. So in short, if you use this approach to try to figure out how many feedback scans are optimal, you're at risk of grossly overestimating the optimal number. And that's going to cost you a huge amount of time and money later on when you're running 12 scans instead of 2, for example. So sadly, the only really dependable way to optimize number of sessions in a real-time fMRI neurofeedback study, in my opinion, is to run a multi-leg intervention. And that takes a huge amount of resources because you have to randomize people to multiple different groups where one group gets 1 session and is followed, another group gets 2 sessions and is followed, and so forth. And that's very resource intensive. I do appreciate that, but sadly, I think that's the implication of our finding. So I just want to acknowledge the contributions of people to this work. Mariella Rance ran the OCD study, and Chris Pittinger was our primary clinical collaborator on that study, and a lot of the OCD research clinic staff helped us with that. The Tourette syndrome study was run by Christopher Walsh. Our primary clinical collaborator was Dennis Subudolsky, and the Yale Child Study Center Tic Disorders Clinic helped us with that study. Dustin Shinos has helped a lot with some of our technical issues, and Brian Pittman is the statistician who helped us with the omnibus analysis. He wouldn't give me his picture, so I had to sketch him here. So this work has been supported almost entirely by NIMH, but we've had some foundation grants, which have also been super helpful. So thank you for your time.